Okay. So, radiation biology. So, a little bit of science left. Mostly this, I think this is kind of like our last sort of sciencey one that talks like cellular stuff. And then after that, mostly everything has strictly to do with X-rays. So the way we look at X-rays, the quality of the X-ray, if it's blurry or if it's light or dark, and then things that you can see. So diagnosing or interpreting, I guess is the better word to say, interpreting X-rays. So this one is the last one that has a little bit of kind of more of a sciencey content. So we're going to explain how tissues are affected by radiation. We're going to discuss factors involved in tissue damage. We're going to discuss the various units used in radiation measurement. And with that, it's really a simple, very simple concept. You just have to remember two or three key points with that. We don't go in depth with that because that kind of goes way beyond what we need to know. Discuss precautions taken to reduce radiation, and that's kind of some basic things that are pretty simple to understand, and some of you are already familiar probably with that. And then explain the concept of risk assessment when taking radiographs. So that's mostly, I really want to get to that point so we can have a little activity. So hopefully we can get through this PowerPoint so we can think through some of the ways that we would actually prescribe radiographs, because especially if you've been in the dental office, it's very much dictated oftentimes by insurance. And so it's hard to sort of step outside of that and think about it in a different way. So I want to get to that and do a little activity with that. So why is it important to have knowledge of radiation biology? Basically, it's because the radiation that takes X-rays is ionizing, and we'll talk a little bit. We've used that word. You've seen that word already come up on some of the material, but basically that ionizing radiation causes physical damage. Like that's the easiest way to think about it. It disrupts our cells. It either leads to cell death or some kind of a mutation. And of course, when that all sounds like really not great, but it's very minimal and our bodies do heal. So it's all based on a dosing and a quantity and then how long you're being exposed. So obviously, a long, lengthy exposure to ionizing radiation potentially is very bad. A very short, quick, low dose in a very small area is really negligible, especially if you compare it to things like flying on an airplane or, other things that people do every single day. So we have to take it seriously, but we don't have to be scared of it. So that you just respect the energy and understand it and know how to use it safely. And it's really not scary. So all radiation is harmful and produces biological changes in living tissue. That's sort of the main point. So two concepts that we want to be aware of: excitation and then ionization. So excitation is basically when the radiation comes in and it excites the cell or the atom. So it causes, everything to kind of move around and jiggle around, and it might settle back down and nothing happen, or it could excite it so much that it does actually break the bonds. So excitation, an X-ray photon. So what's coming out of the machine now we're at the human level. We're dealing with what's happening to the human. So excitation, an X-ray photon interacts with an atom, an orbiting electron, and it causes that electron to vibrate. So basically just causes the atom to kind of get shook up a little bit. And it basically, two things happen. It'll either produce a little bit of like maybe kinetic energy or some heat, or something will kind of come off of it, and then it'll settle back down, and it won't necessarily cause any kind of damage, or it'll break those molecular bonds, and that electron will get discharged, and you'll end up getting damage to that atom. So two things can happen with excitation. It could be potentially harmful, or it could just sort of settle down. Ionization is different. It's definitely, you have some disruption of the electron. So the electron is ejected from its shell, creating an ion pair. So now you have a positive, you lose that negative electron, and now that atom is positively charged. And when you lose the negatively charged electron, now you have just a floating free negative electron. And so they're both unstable, because everything wants to be neutral, right? It wants to have it wants to complement each other and have a neutral energy. So if you have one negative and one positive, now they're going to be looking randomly for a pair. So the atom's no longer electrically neutral and it becomes chemically reactive as it attempts to find an electron to replace the missing one. So it's could come up with something that's not necessarily healthy. So it could pair with something and make some new combination that's not necessarily healthy for you. So this is just another little diagram. It shows the X-ray photon interacting with tissue. You can have excitation, which could potentially be nothing, but it could break the bonds and lead to chemical change. Or you could have just direct ionization, and that would be a chemical change, and which leads to a biological change. So this is kind of an example of, let's see if I can get this to play. Of course, it plays over here. Kind of soothing and pretty. This is like an example of like excitation, basically. Things get kind of worked up, they move around inside the atom, but nothing necessarily breaks. It's 4 minutes. We're not going to listen to 4 minutes of beautiful, soothing music, but you might want to while you're studying. I just like that video. Isn't it cool? And I love this song too. So, okay. I'm tempted to just play it, but I won't. But go ahead and go if you want to listen to the rest of it. And then the TED Talk is also, let me see, how long is it? I might be able to play it if it's not too long. It always pops up over here. Just like things are packed tight inside. Get auto insurance to fix your budget and your needs. Save up to 10%. 5 minutes. Okay, I might edit it early. We'll see. We'll see how it goes.
It's tempting to picture huge explosions and regions, but that's not the full story. Radiation also applies to rainbows and a doctor examining an X-ray. So what is radiation really, and how much should we worry about its effects? The answer begins with understanding that the word radiation describes two very different scientific phenomena: electromagnetic radiation and nuclear radiation. Electromagnetic radiation is pure energy consisting of interacting electrical and magnetic waves oscillating through space. As these waves oscillate faster, they scale up in energy. At the lower end of the spectrum, there's radio, infrared, and visible light. At the higher end are ultraviolet, X-ray, and gamma rays. Modern society is shaped by sending and detecting electromagnetic radiation. We might download an email to our phone via radio waves to open an image of an X-ray print, which we can see because our screen emits visible light. Nuclear radiation, on the other hand, originates in the atomic nucleus, where protons repel each other due to their mutually positive charges. A phenomenon known as the strong nuclear force struggles to overcome this repulsion and keep the nucleus intact. However, some combinations of protons and neutrons, known as isotopes, remain unstable or radioactive. They will randomly eject matter and/or energy from this nuclear radiation to achieve greater stability. Nuclear radiation comes from natural sources like radon, a gas which seeps up from the ground. We also refine naturally occurring radioactive ores to fuel nuclear power plants. Even bananas contain trace amounts of a radioactive potassium isotope. So if we live in a world of radiation, how can we escape its dangerous effects? To start, not all radiation is hazardous. Radiation becomes risky when it rips atoms' electrons away upon impact, a process that can damage healing. This is known as ionizing radiation, because an atom that has lost or gained electrons is called an ion. All nuclear radiation is ionizing, while only the highest energy electromagnetic radiation is. That includes gamma rays, X-rays, and the high energy end of ultraviolet. That's why, as an extra precaution during X-rays, doctors shield body parts they don't need to examine, and why beachgoers use sunscreen. In comparison, cell phones and microwaves operate at the lower end of the spectrum, so there is no risk of ionizing radiation from their use. The biggest health risk occurs when lots of ionizing radiation hits us in a short time period, also known as an acute exposure. Acute exposures overwhelm the body's natural ability to repair the damage. This can trigger cancers, cellular dysfunction, and potentially even death. Fortunately, acute exposures are rare, but we are exposed daily to lower levels of ionizing radiation from both natural and man-made sources. Scientists have a harder time quantifying these risks. Your body often repairs damage from small amounts of ionizing radiation, and if it can't, the results of damage may not manifest for a decade or more. One way scientists compare ionizing radiation exposure is a unit called the sievert. An acute exposure to 1 sievert will probably cause nausea within hours, and 4 sieverts could be fatal. However, our normal daily exposures are far lower. The average person receives 6.2 millisieverts of radiation from all sources annually, around a third due to radon. At only 5 microsieverts each, you need to get more than 1,200 dental x-rays to rack up your annual dosage. And remember that banana? If you could absorb all the banana's radiation, you'd need around 170 a day to hit your annual dosage. We live in a world of radiation. However, much of that radiation is non-ionizing. For the remainder that is ionizing, our exposures are usually low, and choices like getting your home tested for radon and wearing sunscreen can help reduce the associated health risks. Marie Curie, one of the early radiation pioneers, summed up the challenge as follows: nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less.
So there's we'll get to some of that other stuff in a little bit too with the sieverts. But that concept too of like the dose and stuff, I liked that video because it kind of balled it all together. The nuclear stuff, that one section, you don't need to know anything about isotopes and nuclear radiation. Okay, let me go back to my notes here. Okay, so basically, so just where we were at, so if the molecule gets broken, you basically get 2 results. You either get the function of the cell is lost or the cell dies. Either one is not great, so neither one of those are good outcomes. And this basically just shows, this is like another sort of flow chart similar to the one I showed a few slides earlier. X-ray photon you can have excitation, just sort of a harmless vibration, reduce kind of emitting heat or light, or the molecule can break, which can lead to that permanent biological damage. Or the other pathway is just straight ionization, which will lead to cellular damage. So those are the concepts that you want to understand. There'll be questions about that on the next exam. What are the ways that or radiation can harm a cell, and you can there'll be different options there that'll basically encapsulate this flow chart. So you want to have an understanding of this flow chart. Okay, diving a little bit deeper into what's happening on the cellular level. So the effects of radiation on the atom. So we're mostly water. You guys have heard that in all your early science courses, right? I've heard 70% water. This says 80% water. I've heard different numbers, but our cells are mostly water. And then of the other percentage is a makeup of what I am just terming chemicals of life. And so the chemicals of life are like, your DNA and, ATP and just all these other little cells inside of us that have very specific functions. You do not need to have a memorized list of what the chemicals of life are. You just have to know that we're talking water and then we're talking chemicals of life. And that's all the other important stuff that's inside of our cell. So there is a much higher likelihood that an X-ray photon is going to interact with an atom or a molecule, I guess, really is the more appropriate term, the molecule of water in our cell. So there's a way higher chance, and that makes sense, right? Because it's 80% or 70% or whatever percentage you hear water, and then a much smaller percent of these chemicals of life. So it's just much higher likelihood that the photon is going to interact with water. So an ionizing radiation that interacts with a molecule of water is called radiolysis. You're going to want to know that term as it like memorizing what radiolysis is. So that's what it is. If the ionizing radiation interacts with a molecule of water and causes a reaction, you have radiolysis. Ionized water molecule will form a free radical. And you guys have heard the term free radicals, like, oh, this causes free radicals. It can cause health damage. It's sort of like this nebulous term that you just hear out in the health world about free radicals, or this fights free radicals. It's like, what are free radicals? Well, they're just sort of like rogue, little unstable, you know, ionized cells essentially going around trying to pair up. And when they pair up, they could create something that is not healthy for us. So free radicals, molecules containing unpaired electrons, and they're extremely chemical reactive. So they're going to try and stabilize themselves. So they can create things like hydrogen peroxide inside of our cells, which hydrogen peroxide in and of itself, sometimes we find it useful, but hydrogen peroxide also destroys tissue, right? So if you have a bunch of hydrogen peroxide produced inside your body, you might have some damage. We don't have to worry about that or overly analyze that. That's not really going to be on a test. But that general concept that free radicals are unstable, they're trying to pair up, and sometimes they pair up and create an unhealthy chemical in the body. And that's your general concept that you need to know. We don't need to go much deeper than that. So these are just examples of ways of that can happen. So here's a little diagram. X-rays come in to hit molecules of water. The ionization happens. It breaks up the hydrogen and the oxygen and into all the different things. And then when they recombine, it might recombine into something that's not super healthy necessarily for our bodies. That's where we get some of the cellular damage specifically. So the chemicals of life, examples of them, and I told you don't have to memorize a specific list, but I say that now with also the caveat that you should have a general understanding of what I mean. So if there is a question that says what's the chemicals of life, and it says like water versus DNA, you should know that when I say chemicals of life, I'm meaning things such as your DNA, your RNA, ATP. You don't have, there's not an exhaustive list, but just a general understanding of, I'm talking about the important substance inside of your nucleus, inside the cell. Yeah, like kind of know this slide, but you don't have to know more. So I want, if she's like, well, she never mentioned chemicals of life. What is she talking about? I'm not talking about chocolate. I'm talking about these kinds of things. So there could be a test question. So I just want you to have a general understanding of what I mean by that. Okay, so different ways it affects the cell. Okay, the physical process leading to damage, the chemicals of life, are divided into two categories. So now we're talking about when that X-ray photon comes in and literally, so it's not radiolysis, it's not coming in contact with the water. Now it's coming in contact with the nucleus of the cell or the chemicals of life in the molecule or whatever it is. The direct effect and the indirect effect, and they're kind of self-explanatory here, but we'll talk about it in more detail. So the direct effect, cell damage occurs when the ionizing radiation comes in and directly hits the payload right in the center of the cell, the chemicals of life. The result is going to be death of that cell. It's going to damage the DNA, it's going to damage the RNA, whatever else is inside that nucleus. And this occurs more infrequently, obviously, because it's a much smaller, when they talk about the size of a cell and the nucleus is super tiny, it's like a football field and a football, so it obviously is going to happen much less frequently because where that the chemicals of life exist in the cell is a much smaller space. So that the direct effect is not going to happen as often as the indirect effect. Ionizing radiation with the indirect effect is going to cause the chemical breakdown or the molecular bonds to break down, which will then lead to either cellular death or just the function of the cell. So the indirect effect, if I back up to like something like this here, when we look at the excitation and we go from just harmless excitation to breaking of the molecular bonds, that's an example of indirect effect. So you're going to eventually get to biological changes, but it happens indirectly. So excitation can kind of sit in that indirect effect column. So ionizing radiation deposit into the water instead of chemicals of life. Free radicals form, the radiolysis, the whole process like what we just talked about. And then it's either going to cause enough damage to just kill the cell, or it's going to cause some kind of molecular dysfunction. This is going to occur more frequently because that's what's made up more in that tissue is more water, and so that's going to happen more frequently. It takes radiation time to cause visible damage. So with X-rays, this is not necessarily something that we're ever going to worry about, but we have to learn about it because we use radiation. So our radiation, of course, is very small dose, like we've already said. But in other worlds, in the hospital where they use higher doses of radiation, just because we handle radiation, we have to understand this. So it takes time for radiation damage to cause a visible change. The time between the exposure and the observable biological damage is called a latent period. So if somebody has cancer and they're going in for radiation on their cancer, when they leave, they not necessarily will have something that's obviously some kind of obvious damage, but maybe a couple hours later, they might get almost like what's like a severe sunburn or something. They might, or they might start to, have their salivary glands kind of dry up or not, or become dysfunctional, not produce nearly as much saliva. And that doesn't necessarily happen right then and there when they're getting the radiation. So there's this latent period where the radiation is exposed, and then when the damage actually starts to manifest itself in some kind of a symptom. The good news is cells have the ability to repair damage from radiation. So for a dental X-ray, any cellular damage that takes place is not going to be noticeable to anybody. It's not going to, it's going to happen on such a small cellular level. It's not affecting any function, any main body system function. However, again, somebody that's like getting cancer treatment, they are potentially going to notice some kind of cellular or organ function, deficit that's going to actually cause a symptom that they're going to notice. However, if it's a low dose over a long period of time, then they'll probably recover from that and their body will probably bounce back over time. So if somebody gets head and neck radiation and they have damage to their saliva glands, they will probably notice severe dry mouth. And then over time, they might start to recover some of their saliva, like how much saliva they had. They might always have a diminished amount of saliva compared to what they had before, they had cancer. So that's just an example of having some kind of damage and then your body sort of bouncing back a little bit. But of course, this is going to be dependent on dose and the length of time. So lower dose, more capability to repair, higher dose, there's going to be more damage and you might not bounce back to full recovery. So effects of radiation is accumulative. And so if you get a lot of it over a short period of time, there is going to be a certain amount of, almost like you can think of it as like scarring, like your body's going to just carry that scar of excess radiation. So it just totally depends on the dosage. Okay, so total dose, determining factors for radiation injury. So your total dose, the quantity of radiation received or the amount of the radiation that's absorbed. So those are kind of different things, and we'll talk, they measure them in different ways. So you can remember how we talked about an X-ray photon can come in and it can basically like go through all the cells with no interaction and then hit the sensor and you get the full power of the photon hitting the sensor. Well, that X-ray, that is like part of the dose, but it's not part of what was absorbed. So they measure those things in different ways. And we're not going to get into exactly how that happens or worry about numbers, but just that concept that just because you've been exposed doesn't mean you, or have a certain amount of a dose, doesn't mean that you have absorbed all of it. Some of it might have made its way through your body without interacting at all. So a large dose in general, however, is worse than a smaller dose. That makes sense. There's more opportunity for damage, right? You just have more radiation. And dental x-rays are considered a very small dose. So we're good there. The quality of x-ray, so that's why we care again about the quality. Obviously, higher energy to the x-ray photon could potentially cause more damage, but really it's a kind of a weird concept, because if it's a higher powered X-ray photon, it's going to penetrate better and it's going to get the information that we want on the sensor. So all of this sort of weak radiation is still going to cause damage, but you're going to expose them to this weak, kind of not very helpful radiation, but it still is strong enough to cause cellular damage, but it's not going to give you a really good picture. So we would rather have high energy, deeply penetrating, get through the teeth, get through the cheek muscle, get to the sensor and give us a good picture, in a very low dose, but high penetrating power X-ray photons. So that's our goal. Okay. So determining factors for radiation injury. So the amount of tissue irradiated matters. That's why we use, mostly out in the world, you're going to use a round cone and it's going to radiate a larger area of their cheek. That's just sort of, when they talk about the standard amount of radiation from dental x-rays, they're considering like around PID. So they're taking that into consideration. Ours is even less here. And what the main reason we do it is because you guys are going to have to take more x-rays. You're going to take an x-ray that needs to be retaken because you're still learning, or because our critiquing is stricter than somewhere else. And so we reduce the amount of radiation using a rectangular collimator. But when you think about like the amount of radiation and the information that's out there, they're considering the round beam. So that kind of, it kind of is a nice way to think that, okay, it's even with that, it's still considered low. Even with the round beam, it's still considered low, or the round collimator. Total body radiation produces more adverse effects than a small localized area. So we're not radiating their whole body, we're just radiating their cheek, or their, just small area of their cheek. But we do consider things like the cells that are sensitive. So some cells in the body are just going to be far more damaged, easily more reactive to radiation than other cells. And the easy way to think about this is if a cell is rapidly dividing. So if it's a rapidly dividing cell, and you can think of that in terms of anybody that's young, a kid is growing, right? Their cells are just constantly rapidly dividing. They're growing. They're not done growing yet. So kids are particularly at risk. And then within an adult, you think of the things that rapidly divide. What do you make all day long that keeps you alive? Blood? Did someone say blood? Blood. So like things like a blood cell, you're constantly making your bone marrow, you're constantly making blood. And so anything that is that type of that nature of cell. Now, what kind of a cell do you think doesn't grow and change super rapidly? All of our cells kind of do it a little bit because we're self-healing machines. But what kind of a cell do you think stops growing a lot at a certain point? Bones. Yeah, muscles, unless you're working out a lot. But so nerves, bones, muscles, those those tend to be less, they don't turn over as much. And so that's why. So there's certain cells that are going to be more sensitive and certain cells that are going to be less sensitive. Doesn't mean damage doesn't occur, but there's just different cells. So more damage occurs in cells that are most sensitive to radiation, rapidly dividing, so very sensitive, blood forming, reproductive. So anything in the reproductive area of a man or a woman is going to be highly affected, and then less sensitive muscle cells, nerve cells. Children are going to be more susceptible than adults because their whole bodies are growing. And then the dose rate, more damage takes place with a high dose rate. So if it's, you know, it's like an acute dose rather than a chronic dose. So dental x-rays are considered chronic doses. You get like a small dose once or twice a year, maybe even less frequently. But if you go in for something like maybe some kind of a larger scan or some kind of radiation therapy, that's going to be more acute dose, a larger dose in a shorter period of time, so a higher dose rate. Oh, I kind of said it before I got to the slide. So acute versus chronic. Acute, the energy is given in a short period of time, more severe effects, and of course it depends on the amount too. But especially if it's a large amount given in a short period of time, that's going to be much more damaging than chronic. Small amount of radiation giving in a prolonged period of time. The body has time to repair, to kind of recover in between exposures. So there's just not really any meaningful damage that is going to happen from it. Dental x-rays are a perfect example of that. Yes.
So what about like the instead of radiation, like as an radiation.
Yeah.
And you walking about how much of that is like
The scatter.
taken in.
Yeah, so thankfully it happens so fast that when it scatters and it bounces off the patient's like face, it bounces off and flies to the wall. I mean, so faster than you can walk back in. And so it just happens all like within seconds, milliseconds probably. The one thing that I need a little bit more training on, and I need to wrap my mind around it, is the Nomad. I mean, everything that I've heard, when you hold the Nomad, it's a hand, for those of you who don't know, it's a handheld X-ray device. And it has this sort of donut that's only like maybe this big, like it looks like a chunky gun or whatever. And then it has this shield that's only like this big. It's not like huge. It's not like you're standing behind like a wall. And so it's just like this. And then you take the X-ray, you put the sensor in the patient's mouth, and then you stand behind this little like 8-inch donut or whatever that's attached to the Nomad, and you take the picture, and they say, and it's not that I don't believe them, I need a little bit more time, like just kind of studying the science to make it right in my head. But they say that everything deflects around it. So all the scatter from that deflects around it. And so you're in this like safe zone. People use them all the time. Anybody here used a Nomad in practice? Many hands went up. So I mean, I'm not second guessing it. I'm sure it's true. I just need a little bit more. I just need to do a little bit more reading on it just to make it right in my head, because we're always like, don't stand in the room, da 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 da. And I'm like, really? But they're very popular. We use them on the van. So we have them. We have a Nomad on our dental van. We use it. I'm trying to, this is the first year that because they're more popular, just for the number of hands that went up, I want to have a hands-on practice in lab with the Nomad before you guys go out on the van with Professor Ramirez. And so it's not that like I'm scared of it. I just need to read more about it to like get it in my head as how that works. Um, but they are becoming much more popular. They have, you know, they're portable. They use them in public health. Even offices have them that could have one attached to the wall, but they like their Nomad better.
You kind of answered that. I was just curious why they would use that in like a private practice when they have a regular thing.
I don't know. I mean, everything that's wireless, people like, you know, you don't, it's easy. You can bring it from room to room. You know, if you have a patient in the chair that they're doing some kind of a procedure, you know, the offices that I worked at, we always had them in between the rooms. And so the patient didn't have to leave the chair. There was no x-ray room, but you know, it could be that it gives them even more flexibility. I really don't know that because I've never worked in an office that made that decision, like let's buy a Nomad instead of use the one that's on the wall.
Yeah.
I don't know, but they certainly are though. So, but public health, I totally get it. Mobile dentistry totally makes sense. Going into nursing homes and assisted living totally makes sense. You would almost have to have something like that. But other than that, I'm like, why? But okay. So a little bit more about the different kinds of biological damage that can occur. So there's two kinds of tissue damage. There's two kinds of tissues basically that we're going to divide this into. So we're going to somatic tissues and then genetic or reproductive. So you can think of, it's easy because anything that has anything to do with the reproductive system, making a human, is going to be your genetic tissue. Anything, and then everything else is we're going to call somatic. So, you know, an arm is somatic, your ovaries is part of the genetic reproductive tissue. So we're just basically going to divide it into that. So the effects, so for somatic radiation effects are responsible for the poor health of the individual. So generally speaking, if they're getting a large dose of radiation, they're going to have the effects that they feel, the poor health that they feel because of that radiation is going to be affecting the somatic tissue. And it's only going to affect the person that is getting that radiation. So tissues are not inherited from generation to generation. You don't get your mom's arm. Everything that you get is inside of that genetic bundle in the reproductive system. So it's kind of separated, right? So if an individual is having radiation and it's affecting their chest area or, you know, with their head, that's all going to be somatic tissue damage, and it's only going to affect that. Now, if radiation is somewhere in the area where reproductive organs will be damaged, you pass that on to your offspring. So now that damage can now be seen in generations, you know, the next generation. So damage to genetic tissue is responsible for producing the next generation. Obviously, things like the egg and the sperm, if that gets radiated and there's some kind of damage there, that could pass on some kind of a genetic damage to the next generation. So that's considered more serious also, obviously. And so this is just a little drawing. If the dog gets radiation and it's genetic, the dog might not even feel bad. Like if somebody, you know, some women with, say they have ovarian cancer or something like that, and they have to have radiation, they might not feel overly sick directly due to the radiation. Obviously, this is going to depend on a ton of different factors, and I would think they would feel sick, but just to try and, you know, make this make sense. But if they survive the cancer and they have offspring, they could be weakened, they could be more susceptible to disease, or they could be more prone to cancer, or they could have some kind of DNA, you know, problem that leads to something, or they could be born with something. Somatic tissue, if they get the radiation and somatic tissue is affected, they will feel the effects of it. They'll have some kind of damage, but their offspring, the future offspring, will be fine. So just a little simple drawing that kind of illustrates that. Animals exposed to radiation to the somatic tissues don't produce visible changes in tissue until you hit a certain threshold. So you can think about it, some people, or I guess everybody, will, if you get a sunburn, you're not going to get a sunburn necessarily in 5 minutes, but you definitely might get a sunburn in 20 minutes, or you might get a sunburn in an hour. So that is a threshold dose. So you have to be exposed for a certain amount of time before you're going to notice the effects of the radiation. So that's going to happen on your somatic tissue. So normally requires a larger dose, and it requires some time. So an example of this is the epilation. So the hair loss when people are going through chemo and radiation, and they don't lose their hair right away. They lose their hair, like after they've had maybe their second dose or something like that. Erythema, skin reddening, cataract formation doesn't happen right away. It happens after a certain amount of dosage. Yeah.
When it's talking about threshold dose, what is that?
So it basically just means that like you hit a threshold before you see an effect. So you're getting radiation, you hit the threshold, now you see the effect. And that only happens with somatic tissues. So, because you'll see with the next slide, we call this kind of damage with genetic tissues linear or non-threshold, because basically any amount is a bad amount. So it's like you get some radiation to a genetic tissue, that's bad amount. That's, and that's why, we're protective of those areas when someone gets radiation is because any amount is not a good amount. So exposure of genetic tissue to radiation causes mutation. Mutation changes in the information contained in the chromosomes, the sperm and the egg. And so it's going to affect the generation to come. Mutations follow a non-threshold or a linear. So the more exposure, the worse the damage. So it's not threshold. It's not like, oh, you can kind of go and, it's more like the more you get, the worse it is. So it's a linear response. And this just shows that. Linear, the response is directly correlated to the dose, but with threshold, you got a little bit of leeway, and then eventually it's going to affect it. It's going to, but there's a little bit more of a gap there because it's kind of has to build before it's going to do anything. So somatic tissue for threshold, genetic tissue for linear. I know we started a few minutes late, but let's just take a break till 9. I have 9 minutes until 9. So let's just take a little break and then we'll finish this PowerPoint. And I'm going to pull up my activity too while we're on break. Hopefully we have time for that. I will find it eventually. There's too many folders in the box folder. But there's a short PowerPoint that just has like 5 sample examples that I like to pull up as an activity. So I'll probably have to do that in lab, but we'll talk about prescribing x-rays and how we would do that. We'll still talk about it. I just might not be able to grab the activity, but okay. So going on about the sensitive cells. So we have different kinds of cells in general that we think about as being more sensitive to the damages of radiation. So things like the lens of the eye, it can lead to, if it's, perpetually, there's a lot of radiation hitting that area, the lens of the eye, it can result in cataracts. The reproductive cells, obviously we talked about that, genetic mutation. If it's the fetus or a new pregnancy, there can be congenital defects. So the baby can be born with different issues. Bone marrow, so not bone cells, but bone marrow, because they're constantly generating all kinds of important cells inside of the bone marrow. So that can lead to leukemia. Thyroid gland, that's why, there was a ton of talk in the early 2000s about the thyroid collar. It kind of all went up in like a big, oh my gosh, because I think it was like Dr. Oz or something said something about how important the thyroid collar was, and a lot of offices had the lead vest that did not have a thyroid collar on it. And so there was just, so then patients were like scolding their dentists for not having a thyroid collar on their lead apron. And so, and it's true. I mean, the thyroid gland is a very important gland in the body, produces hormones that are very important to our metabolic system. It's a very important organ, but they, a lot of times things like that get sort of hits the media, and then just people go crazy and get really worried about it. So, but it's also an area that is close to where we're radiating, right? So of all the places on the body, we probably do need to be the most aware of the thyroid. Skin in general, if you get a lot of high dose radiation exposure for a long period of time, then the risk of that would be cancer. Cancer is the concern of the thyroid, skin, and these are things that it can lead to with, again, large doses over a long period of time. And some things obviously are more sensitive. Like if we're talking skin versus reproductive, we're not in the same category, but those are just saying those are long-term, those are negative effects that can happen. Some sooner than others because of the kind of tissue they are. Keep radiation as low as possible in general, but especially when we're thinking about these organs and the effects. So kind of critical organs that we might think about because they're around the head and neck are going to be the thyroid gland, bone marrow, inside, any bone, and then skin and the lens of the eye. So those are the things that if we're going to radiate something that's on sort of a list of, and you can't help but radiate skin. We're covered in skin, right? So it's not to be hyper fearful of it. It's on the list of obviously things that we're radiating is skin. And we could get close to the lens of the eye. I suppose certain, when you guys get into patient care and you have a patient and all of a sudden you have the XCP in their mouth and your PID is like this angle, like it's not like this, it's like this. And you're like, is that okay? Because Dexter doesn't do that. Well, sometimes you have to with a human, or you might be coming down like over their nose and you're like, I never did that with Dexter, but sometimes you have to with a human. So there are going to be ways that sometimes you angle where you could see how some radiation is going to come in contact with their eye potentially. And again, you have to keep in mind the amount that is going to be coming in contact with their eye and, the overall length of the exposure time. It's very minuscule. It's very, very small. But we still talk about it because it's happening, right? It's still happening, even though it's a very, very small thing. So exposure versus and dose. So exposure, the amount of radiation that comes out of the X-ray unit and reaches the person. Not all of it is absorbed. Some passes straight through. We talked about that when we were discussing scatter. The dose or the absorbed dose is the amount of radiation that's literally deposited into the tissue. And then the amount that's actually absorbed by the cells. So we kind of think of those in two different. Dose equivalent, the concept that allows comparison of the biological effect of different types of ionizing radiation. So not all radiation is the same. So dose equivalent just lets them look at, radiation from X-rays as opposed to a higher frequency type of ionizing radiation. So on that spectrum, in that video that we were watching, how the frequencies increase and the penetrating power increases, the dose equivalent just lets them sort of say, well, this much of this kind of radiation is similar to this much of this other kind of radiation. So alpha particles, gamma rays, beta particles, X-rays, they just kind of compare and contrast that. They have all kinds of delightful mathematical equations and they think about it a whole bunch, and we just don't have to worry about all that. Equal doses of different types of radiation produce different levels of biological damage. So it's the general concept is there is a whole world of science and study on this, and they name them different things, and we will get to a few of these names for the dosing and the units and things, but I kind of boil it down to one or two concepts that you can walk away with. So the concepts is that there is sort of an old system and then there is a newer system and they're weighted differently. So the old system, they measure different things. So I think I wrote it. Did I write it in my notes or did I write it on the next slide? Hold on. I feel like I broke it down better on the next slide. This slide has more information, but I like the way I kind of distill it a little bit better on the next slide. But the old system contains the Renkin. It's like a unit. And remember that, do you guys remember that name from anywhere? Renkin? Like day one. The guy and his wife and the ring and yeah. So that should ring a bell. So that's Renkin. So these are units, and then rad what does rad stand for? I always forget. It's Renkin something dosage. Where is it? It's in radiation absorbed dose. So that's absorption, and then REM is I think it's something in man. What is it? Do you have it? It's written somewhere, right? Okay, but anyways, they stand for stuff and they're a unit. And then we are dealing in milliunits because dental x-rays it gives such a small dose. But this is the old system, the Renkin, the RAD, the REM. And it's still used probably somewhere, people talk about it, but this is considered the old system. The new system, they talk more in columns. I don't even know if I'm saying that right. Grays and Sieverts. So they mathematically have figured out, what equals what, like one rad equals a gray, in the equivalency, they mathematically have that figured out. But really all you guys need to know is that there's an older system and there's a newer system. And really nowadays they talk in the newer system. So that's really all you really need to pull from that. And in general, so comparing rad and REM to Gray and Sievert, radiation, see, I wrote it all out. That's why I like this slide better. Radiation absorbed dose is the rad. That's the literal amount that gets absorbed into your tissue. And that is comparative to the Sievert, which is sorry, I already said it wrong, to the Gray, which is measuring the absorbed dose, but they call it a Gray. And the math is different. But the SI units are also the newer ones. So not to confuse you, but when I write SI unit, I'm talking about new system. That's basically all I'm talking about. So that's what SI unit means. I don't think I clarified that on this slide. But so rad absorbed dose is the same as, or a rad is the same as a Gray. They're just different. They have to be measured differently. So one Gray is going to be like 100 rad. So if you're talking about, they absorbed one rad of radiation, that is far less than one Gray of radiation. That's the concept that I basically want you to walk away with. So you need 100 rads to equal a Gray. So they're both absorbing the amount that a person gets absorbed, and they figured out the equivalency. But if you're like, I was exposed to 2 rads of radiation, I was exposed to 2 Grays of radiation, vastly different. And that's the concept there. Okay, so now we'll look at it with the next kind of comparison. So dose equivalent, biological effect. Traditional measurement is REM. It was Radkin equivalent in man, I think is what it stood for. And so the SI unit or the new system, they talk about it in sieverts. So again, you can see it's the exact same thing. One sievert is like 100 REM. So it's the exact same thing. If you're talking about one REM versus one sievert, they're not the same, vastly different, way stronger, way more exposure in the sievert. And that is your basic point. I want you to know there's an old system, there's a new system. Know the rad, REM, and R go under the old system. New system is sieverts in Gray, and the sieverts in Gray are 100 times bigger than the rads. And even if you know that, you'll get any question I ask right on the exam. Important to know that Grays and sieverts are 100 times larger. Do you guys have any questions on that? Did I make that clear, or did I bumble through that to make it clear as mud?
So Grace Sieverts are 100 times larger.
Yep, they're 100 times larger than a RAD or a REM. So RAD and REM are your old system of measurement of absorption and dosages that are, and then Sieverts and Grays are the new system, and they just measure them. They're just larger. Every unit is larger than the old system. 100 times larger. Here is a nice little chart. There's different ones you can see online, but this one shows, it's kind of neat because it shows one bite wing with a rectangular collimator is what is this in? This is in milli. Examination type using, millisieverts. It's in millisieverts. So one bite wing with a rectangular collimator is 2 millisievert. 4 bite wings with a rectangular collimator is 5. 1 bite wing with a round is 9. So you can see how much, I mean, we're still talking like a tiny, tiny little dose, but you can see how much less one rectangular collimated X-ray is compared to a round. So that just sort of, and then when you're talking a panos are panos, you just get what you get. But when we're talking complete series, oops, go back. When we're talking complete series, this is pretty crazy. An FMX with the rectangle, so the FMX that you take on patients, if you don't have retakes or you only have 1 retake or 2 retakes, you're only in about the 35 to 40 millisieverts. But with a round, you go all the way up to like 170 plus, depending on if you have retakes. So it's huge difference. Yeah.
How come more offices don't use a rectangle?
Because you get more cone cuts, traditional. Like we get you guys so that you don't have that many cone cuts. So I don't think it's really a problem, but that's the short answer. You're going to get more cone cuts. Then you're going to maybe have to take a retake. And so they kind of figure like, but if you get trained on it, you'll learn to get it in the right place. We don't have an overwhelm, and I say that with trepidation because you guys are using new XCPs that the past 8 classes didn't use. So I'm like, ooh, please don't prove me wrong. But we don't have a huge problem with cone cutting. It happens, totally happens, but not like excessively. So my hope is that you guys all adapt well to that. And it is different. It is totally different. So, I went in there knowing that could happen because that target is different. But so far, I feel like you guys are doing really good. So I have high hopes. But that is why, because, that's what they'll say is we'll get more cone cuts. It's easier to get a better image with a round. You have just more room for error, which it is true. I do believe that's true. I don't think they're making it up, but you can be trained out of it. I think you could be trained into a good picture with a rectangle. Okay, what does this slide say? Assessing risk from dental radiology. So 20 millisieverts average over 5 years for a radiological personnel, someone that works in, employee in a nuclear industry or a hospital worker, someone that's exposed to a higher dose, they're probably going to get around 20 millisieverts. I feel like that's not right. That doesn't make sense micro. So that could be millisieverts. Okay. So it's larger. That person that works in that area is going to get a much larger dose than like a patient or, just someone average because they are in and around radiation. So, but they still have found like X amount is your limit. And then below that is, you're at a higher risk, but hopefully you won't have any long-term health effects. 3 millisieverts for a year is the typical background radiation from natural sources in America. So that's the sun, that's radon coming up out of the ground or the rocks. Radon is one of the, in certain areas in the world, there's more radon being emitted from, granite and the earth. Then, of course, there's the sun. There's all of our electronics that we just are bombarding ourselves with. There's food, they radiate food. You fly in an airplane, so there's just gobs of places that we are exposed to natural background radiation. So about 3 millisieverts a year. Really important principle for you guys to memorize. You got to know this for my exam. You got to know it for the national board. They just love this phrase. ALARA, and what it stands for is as low as reasonably achievable. So as low as reasonably achievable. And it just means that we're doing all that we can to not over radiate our patients. Like if you take a good film because you are purposeful, you're specific, you have thought about placement and you've thought about where you should put the sensor and you've considered their mouth and their anatomy. Like in the beginning, your nerves are usually kind of all up in your head and you just kind of shove it in the patient's mouth and tell them to close and hope for the best. But really, like after the nerves kind of settle down, and hopefully you would do this right out the gate, but I understand when it doesn't happen perfectly, you would like look in their mouth and like study, like you would look inside their oral cavity before you put the sensor in there. Like that's the goal, is like, let me look at the landscape. What am I dealing with? Do you have tori? Do you have a small mouth? Do you have a huge mouth? Do you have a narrow palate? Do you have a big palate? Is your tongue crazy and in my way? And so you take all these things into consideration and then you try to get the best picture that you can, having taken all of those things into consideration. So ALARA is as low as reasonably achievable. It's obviously talking about radiation, and it just means that you're just going to try and do your best to take the best pictures the first time so you don't have to you can minimize your retakes. For patient protection, take only the needed radiographs. We're going to base this on their history and your clinical examination. So we're not, it's a challenge. You will go into an office and the doctor's going to be like, I just every 6 months. That's what insurance pays for. That's what I'm going to do. And you might be like, I have a different philosophy. And so you may have to gently persuade a different philosophy, but it can be challenging. And then other offices can be really laid back and their philosophy can go right with this, that we only radiate patients based on their need, So if somebody doesn't have caries, they don't have cavities, and they've never had a cavity, and their oral hygiene is really good, they could literally go like 2 years, maybe even a little more without having an x-ray. Because why? No pain, great OHI, never had a cavity. Why do they need x-rays every 6 months or even once a year? I mean, so you can use this kind of clinical judgment, but sometimes the office that you're in, you're dealing with a business and a business model and a dentist with a philosophy. And so you don't want to go in there like just I'm going to change this everything. You have some tactfulness around it, but it's legitimate. Build your case and talk about why you were taught this in school, and it's legitimate for sure. So take them I already said it. Take them well the first time to redo the retakes. Kind of went on a little soapbox there, so sorry. Okay, so radiation protection, other things that we think about that help protect ultimately the patient from excessive radiation is film speed. I don't know that you're going to be asked that. That's a question based on traditional films. I tried to take out all my questions based on traditional films out. I'm not 100% positive that I took all the questions out of all the exams. So I suppose it could be on the national board, but back in the day, the traditional films, the way they made it with the chemicals on the film, the more reactive it was, the faster it reacted to the radiation, the less dose of a radiation that you needed. Now, when they came out with digital x-rays, it really made a big jump. It went from, we need more radiation to we need way less radiation because the digital x-rays are so sensitive. But film speed, back when people were using traditional films, mattered. So there was like film speed A through F, and F is the fastest. Kilovoltage, we've talked about that, the power of the photon, the filtration of the beam, reducing all the kind of weak, unnecessary X-ray photons through that aluminum filter, and then collimating the beam. This is just kind of review. Collimating the beam, the rectangular is going to have less radiation. A long cone is preferred over a short cone because it reduces the amount of spread. So if you have a long cone and it's kind of funneling that X-ray beam, that primary beam down the long cone, by the time it comes out, there's going to be very, very short amount of spread. Whereas if you have a short one, it's just going to spread, it's going to spread faster. So it just sort of funnels that beam down and it makes it so it doesn't spread as much. So the collimation, this is just showing the difference between the red is the round beam or the round collimation, and then a rectangular collimation. So this is just highlighting the reduction of radiation using a rectangular beam. XEPs help to minimize errors, and so therefore helps to minimize retakes. So that's why we use pretty much universally most people. Some people prefer there's something called a snap array. It holds a film. We'll use it in class just so you guys can like look at it and play with it. Some people really like using snap arrays. Some people like taking all their bite wings without the ring. They were trained on it. They take good x-rays. But in general, you know, the XEP system has helped people who maybe weren't as intuitively good at taking films, kind of standardizes the x-rays. So that's why you'll find them in most all offices. So I left this in here because there undoubtedly you probably will come across an office. You might work for an office that still has a lead apron. Certain states, maybe more than others. Certainly there are states that nobody has changed their regulation. Everybody still gets a lead apron. They get a thyroid collar, but there was an official sort of ADA, American of Dental Association announcement that the lead apron, they have done studies and they say that it holds scatter to the body. And I hate this topic because, you know, when when you're taught something and you do it for 25 years and then all of a sudden they're like, nope, it's bad for you. It's like, what? So but this is what they say, their studies have done is that there is no more benefit of having a lead apron and covering the body than just letting the scatter bounce off the face and go in the direction that it would go. That if inside of the lead apron, if there's scatter, that it could hold it into the body. That, don't ask me how they've done these studies. I don't know how they did the studies, but it's been a topic of conversation for a very long time. And they officially made a position, the ADA, that they basically are telling people that those of you who don't want to use it, we are not going to say, oh no, you're doing a bad thing. So they're almost leaving it up to the people out there in the different states, but different states have different regulations. So some states are like, nope, we're sorry, lead aprons, you have to. And others are saying children still have to. And then others are saying, nope, don't worry about it, it's fine. So so depending on where you go to work, you might see different protocols. So I left this slide up there. I'm not going to test you on lead aprons and any of that, the theory around it. All you have to know is that in our clinic, after several years of considering it, we finally said, okay, we're just going to go with what really is a lot out there. The main, you know, we're kind of following the trend of what's out there in Oregon. And we still have a lead apron. We have a sign that says, if you want a lead apron, you can have it, but we're not training you guys to put lead aprons on your patients because that's just kind of falling in line with what's really kind of going on in the world. Okay. Patient protected processing, avoiding retakes. This is also very antiquated. I don't have any questions on processing and how to do it. But back in the day, if you processed it wrong, if you opened it up in the light area, you'd ruin the film and then you'd have to re-expose the patient. So it used to matter more before digital.
What about for a pregnant?
Yes, so you know, that it's such a conflicting thing because my instinct says, yes, cover their belly. Like that's what my instinct says. But you know, this study information that the ADA put out makes you think like, should we not cover their belly? So I kind of almost say for years and years and years, hygienists and dental hygienists took x-rays. We covered women's bellies. It is a very low dose of radiation. I firmly don't believe that any, you know, babies got damaged from like a bite wing. I don't think that that's true at all. So I feel very confident in that. But so more than that, I would probably say if the person wants it, unless you have done your own research and you are convicted that they are better off without a lead apron, I would say leave it up to them. Because I think ultimately there's probably negligible risk of anything with one X-ray or a set of X-rays. And so I do think that in Oregon, we still have pregnant women and children, specifically, that need to be covered. But California, I think, is different. I don't think they say anybody. So again, it's kind of a little bit of it's a little bit of a gray area. And I would always probably leave it up to the patient. The other thing with radiation and pregnancy is there's a safe zone. You know, usually you don't want to take x-rays in the first trimester. Second trimester is usually fine, but really any pregnant woman usually will say, unless they are in pain, they'll defer it to after they've had the baby. It's 9 months. Not much is going to happen in 9 months unless they've let something go and they're in pain. That's a different story. But very oftentimes you can totally take an x-ray. It's not the end of the world, but a lot of times they defer. They're like, I'm just going to do it after I have the baby because they're just like, why not? It's, you know, it's not life or death. And so they err on the side of that. But it's a good question. It's not, I don't feel like it's an easy answer. It's not totally black and white. Okay, so more of so radiation protection for you, for the operator. You basically you just don't, unless we're talking about the Nomad where you're holding the Nomad, you don't want to be in the room. You don't want to get in the habit of holding an XCP. And this happens. People do this all. I have worked with so many assistants and hygienists who are like, I'll just hold it, go push the button because you have a hard to deal with patient. And so you end up just like trying to get the x-ray the best you can. And so they're like, I'll just hold it, go push the button. It has happened a lot in the world. But we say, don't have that be you. You know, don't do that because if you do that accumulatively over a 30-year career, that's a lot of x-ray exposures that you didn't need to have. And there are other ways of dealing with it. So don't be the one to hold it and say, just go push the button, I'll hold it. Even though that can be tempting sometimes when you just want to get the picture. You're just like, oh, this patient, I just want to get the picture. Primary radiation does scatter off the patient's face. Anything that lowers the dose to the patient is going to lower it to you. So the same things, collimator, aluminum filter, and then the operator should never be in the direct beam. Like you should never be and that sort of is common sense. Standing at least 6 feet away from the primary beam helps. So that is a protective measure. Stand outside of the room. Of course, you're not going to get any radiation because it's going to be absorbed into the wall. And drywall is fine. It doesn't have to be a lead-lined room. You know, drywall will absorb the radiation. Now, do you guys know in the operatories, you all have been in there, do you guys know there's that little window? Dexter or your patient should always be looking out the window. Always, always, always. And there's a couple rooms where there's a little tiny bit of leeway, like you could swivel the chair a tiny bit and it doesn't matter. But if Dexter's or your patient is not looking straight ahead, and say you turn the whole chair to the side, so now Dexter or your patient is looking at a wall, when you take one of the directions, that beam is going to go straight out the room. And so it doesn't, the room that's over by the window, it kind of doesn't matter as much because just the way that room is designed. But the rooms that are more central, that the radiation could potentially fly out of the room and then hit a passerby. And of course, it would be a very tiny amount, but still, we want to be safe. We want to avoid any of that. So that's why you always put Dexter facing that little viewing window. Because if you think about it, radiation will go this way and hit the wall, it'll go this way and hit the wall, or it'll go this way and hit the wall behind. But if you turn Dexter, it could go right out the front, the opening, the door. So you always want Dexter to look out the window, never stand in the direct line of the central ray, never hold the film, never stabilize the tube head during exposure. You just want to set your XCP and then leave the room. And this is just kind of showing like where the primary beam is and that sort of safety window there because of the scatter. And I think scientifically, I just haven't wrapped my head around it, but I think that's how the Nomad works, is because of where you're standing in relation to the beam. So I think that's why the Nomad is safe to use. I just have to wrap my brain around it so I could explain it better. There is radiation protection for the operator. There is a maximum permissible dose, the MPD limits, and basically there's very little chance of either somatic or genetic injury within these doses. So the MPD for a radiation worker is going to be 50 millisieverts for the whole body. So that's much higher than the general population. You can see for the general population, it's going to be 5 millisieverts for the whole body. And then pregnant operators fall under the lower guidelines. There is also something that you can wear called a dosimeter. I wore it when I was pregnant with my oldest daughter, just because I wanted to see how much radiation I was getting. And I was just, like wanted to be really super healthy. And so I cared about all the things. And so I wore it and it never registered anything. Like it never came back with like a ding of anything. So that made me feel better. And I, always left the room, and I didn't wear a shield and leave the room. Some women do that. But I just left the room like I normally did. So I didn't change any of my habits. I just simply wore the dosimeter, and it never registered anything. So it measures radiation. Okay, so that is the end of that PowerPoint slide. I do want to show you guys, does anybody have, while I'm pulling up this next thing, does anybody have any questions on that? I'm going to pull up. Okay, so two things. I'm going to pull up this radiation guidelines. Oh, you do have a question. Go ahead.
Sorry. National board, when it comes to questions that they have about things like the lead branded and all those stuff, is it gonna be going off what the ADA is talking about?
Yeah.
Or is it gonna ask us about like, oh, you're in Oregon, you say, what are their guidelines?
Very good question. It would be off of national guidelines.
Okay.
So it would be off the ADA. Because it's a national board, they're giving the same test with the same types of questions. And this is what gets a little tricky. But the good news is there's a lot of questions, and every test is different. But you're being asked the same questions that someone in Louisiana could be asked. So it's a mix of questions. So they try to go down the middle of the line. They try, Oregon has a very broad scope. We're more progressive. The way that Oregonians, view dental hygiene is very different from, even Texas, for goodness sakes, it's a very different scope, but the national board's the same. The questions are always a mixed bag. Like you and your neighbor are going to get different tests, but it all comes from the same bag of questions. It's just, you don't know what questions they're going to pick for you, but that's a great question. Okay, so this right here is in your Moodle page, and it's recommendations, and this has, I checked it 6 months ago and it hadn't been updated. I probably should have checked it right before class, because sometimes, but I don't believe a new one has come out. You can find this on the ADA website, and this is their recommendations for prescribing dental radiographs. Now you can read this down the list. It is divided into new patients being evaluated for oral disease. New person comes into your office. These are the different things you're going to think about. Recall patient, meaning this is an existing patient in your practice, but now they're coming back for their, we call it their recare appointment or their recall appointment. And they have with clinical cavities or caries, we call it the layman's term cavities, we call it caries, clinical caries, or their increased risk for caries. So here's their recommendations all the way down the line, depending on if they're a child with a baby teeth primary dentition, whether they're a child with a transitional dentition, they have some baby teeth, some adult teeth. They're an adolescent with their permanent adult dentate or partially edentulous. That means they're an older person, they've missing some teeth for some reason, or they're totally edentulous, they have no teeth. So you're like, why would we x-ray? Well, they do still x-ray, they want to see the bone and things like that. So as you go down this chart, you can see that it breaks it up in a number of ways. So we can kind of see the difference a little bit. And actually, I don't want to spend too much time here because I want to show you this really cool thing. So I'm going to show you, I have to back up. This is the Moodle page. Okay, so in the Moodle page, so here is the radiograph prescribing guidelines. That's what I just had up. And then if you go one down below, radiographic selection tool, there was a work group that did, I don't know if it was students and faculty or if it was just faculty who did this. I don't exactly know how it came about, but they did this for some kind of a project and they presented it to ADEA, which is, you guys, you know what, it's the American Dental Education Association. They presented it at ADEA, and it is this totally awesome tool. And I was inspired by it, and I took a student group and we did something similar for nutritional counseling. We made our own hyperlink tool. But this is basically that document that I was just in, that the ADA breaks down the prescribing of x-rays. They took that document and they made it into a hyperlink PowerPoint. So you press on main menu and you say, okay, who's my patient? Is it a child with a primary dentition? Is it a child with a transitional? Is it an adult? Or is it an adolescent? So let's click on adolescent. And so now we have, are they a new patient? Are they a recall patient? Assessment of dental skeletal relationships. So that's other things to think about. And then you can always jump back to different patients. So let's say they're a recall patient. Okay, well, are they a recall patient with caries or an increased risk for cavities? Are they a patient with no clinical risk, or are they a patient with periodontal disease? So let's see the difference between them having high risk. So the recommendation, if they're high risk for cavities and you're just your average 20-year-old, is posterior bite wings every 6 to 12 months. So it gives you a little bit of a window. And if proximal surfaces cannot be examined visually. So if you can't see in between their teeth, which most people don't have diastemas throughout their whole mouth. So if you can't see, then the recommendation is your standard 6 to 12 months, which makes sense. And then if we go back, if they have low risk, it jumps to 18 to 36 months. So it jumps from every 6 months to up to 3 years. So that's a huge change, right? And so this shows you that there is more critical thinking and there is more evaluation than just your average boom, boom, boom. Now, we live in America. We love our Starbucks. We love our snacks. We tend to have high rates of decay. That's what happens. And so I'm not demonizing offices who take x-rays, because there is there's a high rate of decay. There's a high rate of decay in children, and if you go in there and you floss, you brush, you do fluoride or xylitol or any of these things, you have a healthier diet, you don't sugary snack all day long, you probably will be a lower risk. You certainly are going to have those patients in your office, but there is a lot of decay. But I just want you guys to really be aware of this and not think about cookie cutter answers to everything. You can download this and you could have this at your office. You could just print out the sheet and you could refer back to it, but eventually you're going to kind of have it in your head, but if a patient comes in, this is what I experienced as a clinician when I was in my earlier years, and this document was out in 2012. So I'm not even sure what they had honestly before that. But I would have patients that would say to me, "Why do I need x-rays? I haven't had a cavity in 5 years. You just took x-rays on me a year ago. Why do I have to have x-rays again?" And I'd be like, they're good for you. You know, like I don't, it was awkward. And I'm sitting there in my heart going, I kind of don't know why you need them. It seems kind of silly. Like you don't have periodontal disease. You haven't had cavities. And so I just, but then I go tell the doctor, we got an uncooperative patient here. And then they walk in and, oh, and then they tell them why they need to have them. And so this just gives you information. It gives you information that's supported by the ADA. Everyone is not a cookie cutter. We don't have to treat everybody exactly the same. Some people are going to be higher risk and some people are going to be lower risk. That's my big old soapbox. I love this tool so much though. I think so. Play with it, look at it. And then when we're in lab, if I can squeeze it into lab, I will find that PowerPoint with some cases. And it's just like, you have a patient that's a 20-year-old, blah, blah, blah. This is their diet. This is it gives you like a little case, and then you have to decide what x-rays would you recommend for this patient. So it runs you through a little critical thinking exercise. So I'll try to bring that into lab just so we can do that. And that is, I'm going to let you guys be done 8 minutes early so you can go get a coffee or something. Those a couple other resources here. There's an FMX to critique, and there's a key, and I think there's a video on critiquing and determining if something needs a retake. So don't forget when you're in Moodle, look at the resources that are in there, and use those because those can help you from week to week. And I'm gonna pass out your quiz. Do not forget, take one quiz and pass it along. Please don't forget these quizzes are due back to me the following week. So you can always turn it in sooner, but it's due next Tuesday, beginning of class. So don't lose it. Bring it back with you. That is your homework. That's your open book quiz. Okay, now I'm done.